show the overall picture without getting bogged down in all of the details. But please, as I said before, if there are details you want to hear more about, interrupt me. I love talking about brains. That's why I'm here. That's why you're all here, because you love hearing about brains or biology and all this cool stuff. So the basic unit of the nervous system is the neuron. There are obviously plenty of other cells that have different supporting roles, but the main cell in terms of doing actual stuff of the brain, I'm just going to admit, Sarah, the most important principal cells of the brain are the neurons. And so there are other cells that have supporting roles in terms of making sure that neurons are protected from immune invaders or that they have adequate metabolic support, that they're getting all the nutrients they need. But the main cells that are doing all the driving of the thinking, the cognition, all the stuff that you think of the brain's doing are going to be the neurons. And so neurons are organized in this fashion where you have one end, which has all these dendrites. I'm going to switch to the laser pointer view so that you guys can see where my mouse is. And so think of this kind of like the head of a neuron. This is where it receives input from other neurons or from the rest of the body. It receives input on these dendrites. Information gets carried to the cell, gets integrated here, and then to communicate the information from the neuron, it has this long tail called an axon. That axon has stuff on it called myelin that you can think of as kind of like insulation, like all the cables of your computer, like the cable that connects your mouse to your computer. You can think of that like the axon of a neuron, and then the insulation around that wire is like the myelin. And then the final part of the neuron is this axon terminal. And this is where it communicates information to the next neuron in the signaling pathway. So a neuron will receive information up at the top. It'll consolidate, synthesize that information here, transmit that information down this long tail of an axon, which has the insulating material around it. And then it will communicate with either other neurons or, say, a muscle cell if it's a motor neuron that's talking to muscles. And
Actually, it is being recorded.
and that's the basic organization of a neuron. So the basic structure of the nervous system is there's a central nervous system and there's also a peripheral nervous system. But the central nervous system is composed of the brain up top. The brain is divided into different lobes. And then there's also the spinal cord. Both the brain and the spinal cord together comprise the central nervous system. And the spinal cord is divided into segments. So there's a cervical segment up in the neck, a thoracic segment down in the mid back, a lumbar segment lower down, and then finally a sacral segment. The peripheral nervous system is where all outputs from the central nervous system. So say you think about moving your arm, that thought of moving your arm moves down your spinal cord. And then say you want to move your arm, it comes out here. And then it now leaves the central nervous system, goes down the peripheral nervous system, goes down the peripheral nerve, and then goes to the proper muscle that it would innervate. The opposite way of information flow is for like sensory information. So for example, if you feel something rubbing on your arm, you detect that in the skin, that information moves up the peripheral nerve into the spinal cord and up to the brain for you to perceive that information. And that's the basic structure of the nervous system after covering the basic structure of the neurons. So I mentioned on the prior slide that the brain is divided into different lobes. And in normal people, these lobes are not colored, but thankfully we've dissected a cartoon. So we have different sulci and gyri. The brain is wrinkly, as you've noticed. And so the wrinkles and the folds have names. And so the depths of the folds are called sulci. So I'll trace one out here. I'll trace another one out here. This is where the brain involutes, it folds in on itself. Those are called sulci. And then the bumps are called the gyri. And there are some major ones, like this is obviously a major one. And we use these major ones to divide the brain roughly into different lobes. So this blue lobe is the frontal lobe. If you imagine that the eyes are down here, this is going to be the front of the brain. This over here is going to be the back of the brain. This up top is the top, and this is the bottom. So this frontal part, the more anterior part, is the frontal lobe, nice and easily named. Next up is temporal. So the temporal lobe is divided by this really big sulcus here. The temporal lobe gets its name because it sits under the temporal bone. But if you think about where your temples are, and you move kind of down and back, that's going to be your temporal lobe. Whereas up here, you can look to where I'm motioning on myself is more your frontal lobe. As you move back, this is your parietal lobe. The mnemonic that helped me out when I was in college and learning these was that your parents are above you. And so parietal sort of sounds like parental. I don't know if it helps any of you guys. I think in weird ways, but maybe it'll help one of you. And then lastly is the occipital lobe back here. So this is way at the back of the brain. Each of these different areas has slightly different functions. We'll get into those on future slides, but just wanted to highlight that the brain is roughly divided into these 4 different lobes. In addition to these 4 lobes, there's also down here something called the cerebellum, which is involved in, among many other things, coordinating movement, making sure that your movements are not jerky, but are smooth, well coordinated, and something called the brain stem. In popular culture, a lot of people refer to the brain stem as the lizard part of the brain, but basically it's this really old structure of the brain that helps with a lot of reflexes and a lot of super vital functions that are carried out subconsciously. So if you had to think about making your heartbeat every time you made your heartbeat, you obviously wouldn't do as good a job as if it were automated. So your brainstem helps with conducting autonomic and reflexive functions and stuff like that, in addition to conveying information from the brain down to the spine. It's sort of like a bridge in that fashion too. So here's a picture of an actual human brain that's been painted. So again, the lobes aren't actually different colors, but this brain has been painted, and you can see that there's a really deep fissure here separating the frontal from the temporal lobe and the temporal from the parietal lobe, this really deep furrowed fissure here. There's another major sulcus here that divides the frontal lobe and the parietal lobe, and then another major sulcus here helps divide the occipital from the parietal. If you were to cut the brain in half down the middle, so like I said, this is the lateral surface or the outside of the brain. If you were to cut it straight down the middle and look from the inside, this is what it would look like. So you'd see that there is, again, frontal lobe, now colored dark blue. There's the parietal lobe wrapping around the inside, now colored red. There's the occipital lobe colored purple, and then there's a temporal lobe colored green. As I mentioned on that on the first slide showing the structure of a neuron cell itself, there's the neuron body, and then there's that long tail that's covered in that stuff called myelin. So here it is here. So there's the cell body, this long axon covered in this insulating material called myelin. And the organization of most neurons in the brain is that the cell body sits out here in the gray matter, sitting next to other neurons, communicating with each of them, and also communicating with other brain areas. And some of the tails, the axons, are going to dive down from the cell bodies and say it wanted to communicate with a homologous brain area. So say this part of the brain wants to talk with this part of the brain. You would have the axon come down, travel across here, and then go up here and talk to the cell body on this part of the brain. So we have gray matter, which is where the cell bodies themselves are, where the neurons live. And then the white matter is where all of their tails are, all the axons covered in all the myelin. In the spinal cord, you have a similar organization where you have gray matter, but instead of being on the outside, it's now on the inside. And then the periphery, the outer layer, is all the white matter. So all the tails that are going and doing communication to send signals down to the legs to move them, or sending them up from the thumb to say that you're sensing your mouse under your thumb. So that's the gross organization of gray matter versus white matter in the brain. Finally, we have the ventricular system to mention. So there are normally these fluid-filled spaces inside the brain. We won't get into why they're there. There is a good reason for it. But if you imagine that deep inside the brain, if you had sort of X-ray vision, if you were to look from the outside of the brain, you could see these big ventricles that are organized to have some bigger ones on the sides. They drain into a central one, and then that central one goes down and even goes down through the spine. But these are the take-home point from the slide, normal fluid-filled spaces filled with cerebrospinal fluid or CSF. And when you look at them on an MRI, if we cut the MRI this way, so this is going to be something called a coronal plane. The name's not as important as just showing you the orientation of the slide here. But you can see here, you've got your gray matter, you've got your white matter. The colors are reversed on this type of MRI sequence, but I promise it's not that this person has the white matter on the outside. And then you see this white stuff here. These are the ventricles. So these are these two lateral ventricles here. This space is it cutting through this portion of the third ventricle. And then we're also cutting through here a little bit of ventricle out here. But so right in the middle of the brain, you have these normal fluid-filled spaces, which are completely normal. So in addition to lobes, lobes are an anatomical division of the brain, but we can also divide the brain functionally. So different parts of the brain have different functions. You can think of it kind of like a functional topography. So different neighborhoods are responsible for carrying out different functions of the brain. This is a long list. Don't be overwhelmed by the list. I show this just to illustrate the point that specific brain areas have specific functions. So take 3 here, for example. 3 here, we look over to our key, is the motor function area. This is your primary motor cortex. So its primary job in life is to generate impulses that are eventually going to go down to the muscles in your arms and your legs and carry out movement. As another example, you have here in area 4, your Broca's area. In most people, this is on the left, but what it does is it's responsible for the motor production of speech. And all the different parts of the brain have specific functions. Some of those functions, however, are more essential than others. So we can think of the brain as having quote unquote eloquent areas. And when we say eloquent, we don't mean that they speak most gracefully. What we mean is that if you were to miss that part of the brain, say you had an injury, you had a stroke, you had a concussion, you hurt that part of the brain, would you notice a symptom? And so there are certain areas that are necessary and sufficient for generating specific neural functions. So if you were to lose, say, this part of the brain, you might possibly notice, say, some subtle personality or subtle cognitive changes, but it wouldn't be really all that apparent. Whereas if you hit that primary motor area, like we talked about here on section 3, if you hit this primary motor area, you would notice obvious weakness on the contralateral side. So there are certain parts of the brain that are not to say more important, but you would notice symptoms much more readily because these are essential parts of the brain for carrying out essential functions. And there are both primary areas as well as secondary areas. Primary areas are more responsible for really basic functions. So say your primary visual area tells you, hey, there's a bright light, whereas your secondary visual area says that bright light is a green light and it's located on the traffic signal of the intersection. And then as you march out to other association parts of the brain, that'll tell you green light means go, and so on and so forth. So primary areas are more elemental. So again, I don't want to information overload you. I don't want you to memorize the function of every one of these parts of the brain. I just want to paint the picture that different parts of the brain all have different jobs, and some of those areas are more essential for carrying out the functions of the brain. So to get into some cases, I want to try to tie this into what your patients will look like. When they come to you, if you do some shadowing in the clinic with a neurologist, what are some people going to come in and say, this is the issue I'm noticing? Before we get into cases, though, I do want to take a beat and ask if there are any questions that you guys have, anything that you want to clarify, or if there are any other points that you all want to hear a little bit more about because maybe you're curious.
I was gonna ask, what was I missed the name. What was the name of the like bump of the folds
Oh
in
yeah,
the
so
brain?
there are gyri and sulci. So I forget what those words mean in Latin, but the sulcus is the depth of the fold down hiding in that shadowy area, whereas um, the upper part of the fold, the part that I'm tracing out here, this is called a gyrus.
Okay, thank you.
Good question.
I'm just adding to the conversation. Do you have a favorite part of the brain?
Well, as an epileptologist, I feel like I would have to say the hippocampus because the hippocampus in many people plays a very uh, large role in developing different people's epilepsies, but it's also, as somebody who loves teaching and learning, responsible for helping you encode new memories. And so without a hippocampus, you may have some difficulty with learning and memory in addition to seizures and epilepsy. And so for that reason, I love the hippocampus. There's a picture actually of the hippocampus. I couldn't resist putting one in, but this is actually the hippocampus in the brain right here. So it sits really deep inside the temporal lobe. And again, this is the part of the brain that's responsible for encoding or forming new memories. And in a lot of people can generate seizures, but I think the hippocampus is the best part of the brain. Did you have a different part in mind since you were asking about it?
No, I was just asking.
If you wanted to really make a nerdy epileptologist stay, you could ask them which cranial nerve they would be, but we're not going to talk about cranial nerves today. All right. So are there any other questions that we can get to before some cases? Okay. So case number one, this is an image generated by AI. It makes weird looking images, but it's still better than I could ever do. So here we are. So case number one is a case of subacute flaccid paralysis. So first off, just deconstructing terms. This is doctor speak for subacute, meaning it's been going on for a couple days. Flaccid, meaning that the muscles are weak, but they're not stiff. And then paralysis, meaning that there's inability to move the extremities in question. So the case is you have a 19-year-old male comes in because he has 3 days of worsening leg weakness. 2 weeks prior to his presentation, he had a diarrheal illness. He also notices some numbness in his legs, as well as low back pain. These symptoms started in his feet, but over the last couple of days have been slowly ascending. On exam, in addition to both weakness and numbness, which he mentioned to you, you also notice that he has no reflexes in his legs. And this is a little illustration of how you check reflexes. So first up, we're going to talk about the pathways responsible for movement of the legs. So in the brain, as I mentioned before, different parts have different jobs. So the primary motor cortex is going to be this strip right here, this pink one. There's another primary sensory cortex, which is the purple one, but we're going to focus on the pink one right here. So the brain is remarkable in that it's actually organized very specifically, not quite intentionally, because we are products of evolution, not of intelligent design, but the brain is still organized quite specifically. And so if you were to imagine a person where they have their leg dangling down the medial surface of the brain, medial meaning more towards the middle of it, the brain has these two hemispheres, and then there's a groove right down the middle. So if the leg is hanging down the inside, then you have the trunk, shoulder, and then the arm going to the hand laying over the top of it. And then the order kind of switches a little bit. Then you get a large face area followed by some throat. The reason why your hand is so big on this motor homunculus is that there are so many fine movements you can do with your hand. So you need a lot more real estate to house all the nerve cells that are responsible for that. And same thing with the face. There are so many intricate facial expressions you can take, not only for facial expressions and chewing, but also for speech. It's really important that you have a lot of cortical representation of the different muscles of the face as well as the hands that you can move around. Whereas you can see a lot smaller representation of truncal muscles because there's not a whole lot you can do with your trunk. You can sit up, you can, twist side to side, but nothing near so complicated as like, tie your shoes, which you can do with your hands. And so this is the gross organization of your primary motor cortex. That there's this little man kind of laying over the outside of the brain with his legs dangling down the inside. That's up here in the brain. And then in order to get to your legs to move them, you have to get that signal down to the leg muscles. So to move that signal down to the leg muscles, it has to travel down through the brain, down the brain stem, down the entire spinal cord, and then exit the spine along a peripheral nerve, and then contact the muscle and tell the muscle to contract. So to trace that through on here, you have your cell body, and then you have that long axon tail. It's going to pass from gray matter into white matter, move down through the brainstem. It's actually going to cross sides. So if there's one thing you take away from the organization of the nervous system today, it's that most things cross sides. So it's true of sensory information, it's true of visual information, it's true of motor output, it's true of most things in the nervous system, that most things are going to cross sides. So it comes down, it crosses sides in the brainstem, it goes completely down the spinal cord before it enters the gray matter of the spinal cord, and then you have a motor neuron that sends its tail out to contact the muscle to tell it to move. And that's the basics of the motor pathway. To zoom in on the end of the spinal cord, you have all these nerves that are coming down off the spine and they're exiting at all the different levels, depending on which target they have to go out and provide information to. And so the ones that go down to the leg are mostly going to come out down here through the sacrum and then exit and go down into the leg through any one of a couple of different peripheral nerves. Just a brief slide on the reflexes, because what's a neurologist without a reflex hammer? But if you tap on a tendon, it gets detected by the muscle as stretch. That impulse detecting the stretch gets transmitted into the spinal cord, and then there is a reflex loop that then tells the motor neurons that tell the muscles to contract. It activates those motor neurons, they go out, and they tell the muscle to contract, and therefore you get the kick. This is all subconscious. There's no brain involvement here. This is processing done entirely by the spinal cord. I don't want to dwell too much on that, but just think it's fun how reflexes work. So for workup for this patient, so we did a lumbar puncture. You may have also heard of it being called a spinal tap. So the lumbar puncture showed normal white cell count, a normal red cell count, an elevated protein, and a normal glucose. So that elevated protein without an elevated white count, you'll learn much more about in medical school if you do decide to go to medical school. But essentially, this is something called an albumin-cytologic dissociation. It tells us that you're making antibodies. What are those antibodies against? Well, it seems like they're doing something to the peripheral nerves that are helping with detecting sensory information and conducting motor output to the muscles. We also did an EMG, which showed fibrillations and positive sharp waves. Don't worry about what those mean, but basically this EMG tells us that there's active denervation, that those peripheral nerves that go out to the muscles and to the skin are actively being attacked by those antibodies. And then we did an MRI for this patient. And the MRI shows, this is a post-con image, shows that there is inflammation affecting the nerve roots as they go down to exit the spine. Here are the nerve roots again pictured in a slightly different section. So this is if you took somebody and cut them, I'll just blank the screen. If you cut them this way, this is that second image. Whereas if you cut them this way, that's that first image. So if you cut them this way, you're getting this image to the left. Whereas if you cut them from top to bottom, it's going to be this image here. And you can see these nice contrast enhancing nerve roots showing that they're actively being inflamed. So how did he do? So we diagnosed him with something known as Guillain-Barré syndrome, which is where you have an autoimmune attack against the myelin that helps insulate your nerves. He was treated with intravenous immunoglobulin. It's thought that that helps bind up some of the antibodies that are doing that attack. He was given that over a course of 4 days. His weakness plateaued over 2 weeks. So he did get worse for a few days, but then eventually stopped getting weaker. And then by 6 months, he made a full recovery with physical therapy. So I have another case, but do you guys have questions about the first case before we go on to the second case?
Um, I wanted to ask a question that I forgot to ask earlier, which
Okay.
was like, are the axon terminals also in the gray matter, or is it just the cell bodies?
So it depends on where they're going. So if you have, actually, let's go here. So if you have an axon that's going to go, say, to a muscle, then obviously this axon terminal is going to be out in the periphery, stuck in a muscle somewhere. Whereas if you have a neuron that's going to talk to, sorry, close your eyes. I don't want to give anybody a seizure. But if you have one that, say, wants to go from here and then talk to a brain area down here, then yes, that axon terminal is going to be in the gray matter. So the axon itself is going to pass through the white matter, and it's that myelin sheath of insulation that makes the white matter appear white. That axon is going to pass through the white matter, but you're right. But the axon terminal itself is going to be in gray matter so that it can contact the appropriate cell body.
Okay, that makes
Excellent
sense.
question.
Thank you.
Excellent question. I love that.
As a follow-up question, where else would you find like gray matter around the body?
So gray matter in the body is only going to exist in the brain and in the spinal cord. So in the brain, it's going to be on the outsides of the brain. There are also some deeper collections inside the brain that hang out. It's poorly colored, so it may not be projecting well, but there are some deeper parts of the brain that also have some collections of gray matter. And then on the spinal cord, it's going to be more on the inside, but it's only going to be in the brain and the spinal cord that you get gray matter. There are some areas where you may get some ganglia elsewhere, but that's we don't really think of those as gray matter. So when you hear gray matter and white matter, think central nervous system.
Thank you.
Great questions. I love that you guys are so engaged. All right. So other questions we can address before moving on to case number 2. Oh, sorry, there's something in the chat. I realize I've neglected a few things. Yeah, so good points, Rhea. So for that patient, how nerves work is, maybe I'll go back to this slide. So how the myelin works is it helps with conduction. So if you have information that's up here at the dendrite, at the cell body, and you need to move it all the way down to the axon terminal, the neuron does this using electrical fields and using electricity. And electricity, through properties of electromagnetism that are beyond the scope of today's talk, is best conducted when there's high capacitance across a membrane. And so the myelin sheath provides that capacitance. So you're not losing electromagnetic potential across a membrane. And so this helps to insulate the axon. And because of that insulation, the information gets transmitted much more quickly. So this is the reason, in addition to safety, this is the reason why all of your, high tension power lines are insulated and why all the wires of, everything in your house is insulated. It's both for safety, but it's also to help with faster transmission of the electrical impulses across the wire. And whoops, sorry, lost my. Lost. Oops. All right, I'm back online. And I'm sharing. Am I sharing the right screen? Are you guys seeing my slides?
Yep, you're
Yes.
good.
Okay, perfect. So yeah, so this myelin sheath helps with faster transmission of information. And so if you get an autoimmune attack against this myelin sheath, then you're going to get much slower transmission of information down the axon. And over time, if you get enough damage to the axon or to the myelin sheath itself, you can actually cause damage to the axons, and you can get withering of the cells that even convey the information. So that's how generating antibodies against even just the myelin of a neuron can impede your ability to conduct all the information that the brain needs to conduct. I'm just going to pull up the chat and make sure I got all the points I wanted to get. Oh yeah, and the way that the infection caused that is thought to be through something called molecular mimicry. So there are certain infections where the organism that causes the infection, in many cases, or at least in the classic case of this type of disease, there's a bacterium called Campylobacter jejuni. So it's thought that part of that bacteria, at least to antibodies, looks fairly similar to the way myelin looks, just because of some of the similar proteins and carbohydrates expressed on the surface. And so your antibodies, in some ways, don't know the difference between the bacteria that it's trying to fight and the normal healthy myelin sheath that you have in your body. And so it just kind of goes amok. All right, putting up my laser pointer again. All right, so next case is a case of right homonymous hemianopia and alexia. So what these words mean is a right homonymous hemianopia means that you can't see things on the right, and alexia means that you can't read. So the case presentation. This is a 65-year-old female with a history of atrial fibrillation, which is a type of cardiac arrhythmia, who presented 1 week after she had the sudden onset of blindness on the right side of her vision. She also can no longer read, even on the left side of her vision, but she can write, interestingly. When you examine her, she cannot see to the right out of either eye. So if you ask her to close her right eye, she can see out of the left eye when she looks left, but she can't see things on the right. And the same thing when she closes the left eye. Out of the right eye, she can see things that are on the left, but can't see things that are on the right. So it's not an issue with either of her eyes. She's unable to read a sentence, even one that she wrote 3 minutes prior, which is kind of weird, right? So here's a basic overview of the visual pathway. I'm still sharing, right? I got a blip on my screen. Just want to make sure the slides are still showing.
Yep, you're good.
Okay, thank you. So up here at the top of the screen, you can see the visual field. So colored on the left are images, colored on the left are images on the left that are seen in red, whereas in green, you can see images that are on the right side of the world. And then this is your brain as if it was cut going from top to bottom. And so images that are on the right are going to hit the retina, which is the nerve layer in the back of the eye. Images from the right are going to hit the retina more on the left side of the retina, on the temporal side, the outer side. Whereas images from the right in the right eye are going to hit this more medial side of the retina, which is still the left side of the retina, but it's more nasal, it's more medial, rather than being the outer side of the retina. And so like I mentioned for the motor system, most things in the brain cross sides. And so to get images from the right visual field to go to the left visual cortex, what they do is you get the retina from both eyes coming back, and then you have this complicated system whereby some of the information from the retina crosses and some of the information from the retina does not cross, so that we get a matching of outputs so that all the information on this half of the retina and on this half of this retina that's coming from the right all winds up on the left side of the brain. And then it goes from the left side of the brain here, works its way back to your primary visual cortex. There are a couple stops along the way. I don't want to get bogged down in the names of all these different stops along the way, but the overall picture is that this is all in service of getting information from the retina, that nerve layer in the back of the eye, to go to your primary visual cortex in the very back of the brain. And your brain wants to organize it so that everything from the right side of the world is going to appear in your left visual cortex. To show you where language and vision are on an actual MRI, here's your visual cortex. So again, under it, this is the very back of the brain, visual cortex. Here we have your language area. And so in order to read, you know that you have to get information from your visual cortex to your language area so that you can make sense of the written words that you're seeing. And so you can have stuff going through the white matter from this visual cortex here. And there is a little bridge that visual information can take to get from the other side of the brain to your language area. So what happens if we knock that out? If we get rid of the part of the brain that processes this visual information, then obviously you'll get some deficit in terms of blindness. So you won't be able to see the opposite side of the world. But we've also knocked out the connection between the visual cortex on this side, but also from this side, because we've knocked out this bridge. Now no visual information is able to pass through to get to your language center. And we can see on this patient's MRI, we have just such a lesion. So we've hit this area, which is your primary visual cortex on the left, radiology flips side. So I know this looks like it's the right side of the brain, but take my word for it. This is actually the left side of this patient's brain, but just because radiology flips things left and right. So they've lost the left primary visual cortex, so they can't see things that are on their right. But we've also knocked out the connection between visual cortex, both on this side and also on this side, because we've knocked out this bridge. So now no visual information can get to their language area out here. So what's the consequence of that? That even though this side of the brain can still see the words, you can't get the words to the part of the brain that makes sense of words. And so you can see the words perfectly plainly on the page, but you can't make sense of them because your language area is not receiving any of the signals. So for this patient's course, the diagnosis based on the MRI was that she had had an ischemic stroke of the artery that feeds that part of the brain. That part of that specific artery is called the PCA. She was started on an anticoagulation to thin her blood because atrial fibrillation, that irregular heart rhythm we mentioned, is a major risk factor for stroke. So she was started on a blood thinner to reduce her risk of having another stroke. She never regained the ability to see on the right or read normally, but she found some workarounds. So by using prism glasses, she was able to shift her visual field slightly to the right. So what that means is that we put prisms on her glasses, and then prisms help you with refracting and bending light. And so we can sort of shift the visual field a little bit so that it's closer to midline, so that you can sort of compensate for having that deficit of the field cut on the contralateral side. So it can help people with getting closer to being able to drive and do other important things through their daily life. Because as you can imagine, if you have a huge blind spot, that's a major problem for your ability to drive as well as do other things. In addition to the prism glasses, she also learned to read by spelling words aloud one letter at a time. So then she could get words from the visual cortex to the auditory cortex on that left side by saying them aloud. And so since her auditory cortex, which would be somewhere out here, was not affected, you can still pass information freely from auditory cortex to the language area. And so that's the workaround that she found, that rather than going through here, she found a detour starting here and then moving to here. All right. So that was a kind of weird case. That was a case of something that we know as a disconnection syndrome in neurology, where even though her language area was totally fine, it was disconnected from her visual area, which can give you all kinds of interesting presentations. Alexia without agraphia being one of them. So she had the ability to write, but did not have the ability to read. There are other sorts of disconnection syndromes available in neurology, but that's maybe one of the more interesting ones, and one of the ones that we do actually see in clinical practice. What questions do you guys have about that case before moving on to our final case of the evening?
I had a question about that last one, and it was about
did she have like a stroke? And that's what caused her to have like no vision in her right eye?
Precisely. Yeah. So
Okay.
this bright white lesion here is the damage caused by a stroke. And the interesting thing is that so a lot of patients in the clinic will tell you like, oh, I have a problem with my right eye because they interpret the inability to see things on the right as a problem with their eye, but actually it's a problem with their brain. And so when she closes her left eye, she can still see out of the right eye, but she can only see things that are on the left, whereas she can't see things that are on the right. And the opposite is true if she closes the right eye. She can still see things that are on the left, but not things that are on the right. So patients will often tell you that it's a problem with their eye, even if it's actually a problem with their brain. But yes, this patient did have a stroke affecting the specific artery that goes to back here. And that specific artery also feeds a part of the thalamus here. So you can see a smaller area of stroke here as well. But it seems that she didn't have any apparent deficits from this smaller area of stroke here.
Thank you.
Good question. I love that. Anything anybody else was wondering about that last case?
I was just gonna ask, like, so you talked about how like there was a connection between like the vision and reading or like language.
Mhm.
So then are they still able, like you said, like she was able to read out the words instead of like understanding it in her brain, or like how was
Yeah, you're right. That's a little weird, right? So something about the complex like representation of words versus letters, and this is not the case for all people. Some people that have this syndrome are able to sound out at least a letter at a time, even if they can't do the word. But you're totally right that intuitively that doesn't make a whole lot of sense. And in fact, many patients can't even read out a letter. So that kind of workaround, it doesn't necessarily work for them.
okay,
Did that
that makes
answer your
sense.
question?
Yeah, thank you.
Gary,
Okay.
I may have missed it. Did you talk about how the language center is usually on the left side of the brain, so the visual center is not talking to the language interpretation centers very easily in this disorder? Oh, yeah.
I only very briefly mentioned that the language center is on the left, but I didn't explicitly state that it's strictly unilateral. But I have this little schematic. But did you want to elaborate more, Sarah?
No, that schematic is exactly what I was trying to get at. Yeah.
Nice. I've learned well from you. Other points that people wanted to delve a little bit more into?
I was just gonna ask, like, is it possible for like, I guess, again, strokes are probably not like very common in like elderly patient or sorry, in younger patients, but like, if the patient's young enough, can they have enough synaptic plasticity to like be able to like rebuild like a language center in like a little bit of a different area or like,
Ooh,
I don't
yeah,
know.
that's a good question. So definitely younger people have a little bit more recovery than older people. We also specifically see in women that language recovery is a little bit more robust in women for whatever reason. Some of it comes down to how much of your eloquent language area we've hit. So remember on a prior slide, we talked about how there are certain parts of the brain that are absolutely necessary for functions, whereas there are other parts that are maybe just playing a supportive role. So if you were to hit your eloquent language area, you'll have a harder time recovering language function than if you hit an area that's just playing a supporting role. So, for example, there are parts of even the basal ganglia and the thalamus that are also helping with language. And so if you have a stroke, acutely, you'll have a lot of difficulty with understanding people, producing the right words. But with time, your brain will, find other ways to compensate. And you're able to do that to a much greater extent if you hit one of those supporting structures than if you hit the primary area responsible for that specific function, in this case being language. But yeah, there is recovery after stroke. Um, to some extent, it's better in younger patients, and language may be better in female patients. But if you hit this language area on its own, you're probably never going to speak again. All right. Anything else for case number 2? Okay, so the third case is a case of anterograde amnesia, and I think this was probably the best illustration AI spat out for me. I think it's just really great. So a little bit of breaking down these words on the next page, but I'll promise we'll make sense of some of these bigger words. So we have a 34-year-old female. She presented with a low-grade fever. Low-grade just meaning like, call it 100 Fahrenheit or so. She also came in with subacute confusion. Subacute meaning, again, over the course of several days, maybe a couple weeks. Some behavioral changes. She's more irritable. She's angry, as well as anterograde amnesia with confabulation. So anterograde amnesia, meaning going forward, is the inability to form new memories, whereas retrograde amnesia is the inability to recall old memories. So this patient had the first type, which is anterograde. She could remember old things like autobiographical details. She could remember her name. She's not one of those characters from a television show who says that they can't remember their name or where they're from, but she just can't form new memories. And she also confabulates. So confabulation is they can't remember things, but they use cues in their environment around them to just make up facts. It's not conscious lying, but it's that they're just filling in gaps, maybe even without even realizing that there are gaps, and they're just making things up as they talk. She subsequently had a seizure in the ED, and just a few slides on how memory works. So there are a couple different types of memory. There is first sensory memory, which is something that lasts on the order of seconds, and it's usually in your primary and secondary association cortices, but you have this phonological loop. So this is what you use when you're in class, maybe you're not really paying that close of attention, and then the teacher calls on you because they notice you spacing out, and they say, "What's the last thing I just said?" And you're able to spit it out. Even though you weren't consciously processing it, most of us could probably spit out the very last thing they said just because it's still rattling around in our sensory cortex in this phonological loop. Similarly, you also have a visual spatial sketch pad in your primary and secondary visual cortices, which is just like a quick little imprint, a flash of the last thing that you saw. Going slightly longer term, you have short term, also known as working memory, which is what you use to manipulate or rehearse information. So say you need to remember a phone number, or the password to log into your bank account gets texted to you, although maybe not all of you guys have bank accounts just yet. This is what's responsible for that kind of information. And then you have long-term memory, which is something that's more durable and lasts on the order of months to years. Long-term memory is broken down into declarative memory versus procedural memory. So declarative memory is either going to be episodic, so say autobiographical details. I remember the time that I met my wife. Whereas semantic long-term memory is general knowledge. So, I met my wife in Baltimore, but semantic knowledge is knowing that Baltimore is the largest city in Maryland, is an example of semantic memory. Procedural memory you can think of as muscle memory. It's obviously not stored in muscles, even though we all call it muscle memory, but it's these task-specific skills that you learn with time and with repetition. And interestingly, you can have people that learn procedural skills, but have the inability to form new declarative memories. So there are some patients out there that can't form new memories. They have anterograde amnesia, but they can form new procedural memories. So you can teach them a new skill that they can use in the future, even if they can't remember that they learned that skill in the first place, because learning the skill is an episodic memory, or at least the experience of learning the skill. So they might take the skill with them without even recalling that they learned that skill. Memory can get kind of weird. That's why I love the hippocampus and brains. Brains are awesome. You guys should do neuroscience. So a quick little schematic of the limbic system. This is the best part of the brain. This is called the hippocampus. But this is that structure deep inside the temporal lobe that's responsible for helping you encode new memories. So if you think of memory, at least your long-term memories, as a CD-ROM, gosh, is anyone on this talk going to know what that is? A hard drive, I don't know. I've never felt so old. But if you imagine memory as being stored on something physical, piece of paper, the hippocampus is the stylus that writes that memory down. So it's the pen on your paper, It's the stylus for your CD-ROM. It's the thing that helps you actually write the memory. It's not where the memory is stored. It's just the instrument that helps you write and encode that memory. The memories themselves are usually stored in the association cortex. So say the memory is of the scene at the beach, the last time you went to the beach with your grandparents. The visual memory of the beach and your grandparents is going to be stored in your visual association cortex, kind of back towards here. And it's the hippocampus that helps you write the memory into that cortex here. Does that distinction make sense to people? Okay, I'm seeing some nods. So to work this patient up, she had a spinal tap. The take-home message is that she did have HSV1 or herpes simplex virus 1 positivity in the spinal fluid. Her EEG showed a pattern that's highly associated with seizures. She's having these discharges coming out from the left temporal lobe. Here is her MRI, where you can see a little bit here, but a lot here of this bright, fluffy abnormality hanging out in the medial temporal lobe, especially affecting the hippocampus here. This is all the direct viral injury from the infection that she has. This is an encephalitis, itis being inflammation, encephal being brain. So she has inflammation of the brain due to the HSV virus. So she was diagnosed with HSV, herpes simplex virus encephalitis. She was started on IV acyclovir, which is an antiviral. She developed status epilepticus, meaning ongoing prolonged seizures that eventually do cause brain injury if they go unchecked. She then developed a pneumonia leading to a septic shock. She spent 2 months inpatient. Essentially, she had a long and complicated hospital stay. And at 1 year, she finally got back to the point where she was able to care for herself with supervision, but she still had complete anterior great amnesia because she burned out both of her hippocampi, both between the infection and the continued seizures that she had thereafter. So because she burned out her hippocampi on both sides, she had anterior great amnesia moving forward. She also had irritability, and she now had epilepsy as well. So she had to continue on anti-seizure medications for her epilepsy. So that's what I had for prepared material for the cases. We do have some more time if anybody has questions about that most recent case, or if there are any other topics about neuroscience or neuroanatomy or anything else that you guys want to take a few minutes to discuss.
Could you quickly re-explain the thing about the hippocampus? My internet cut out when you said it.
Yeah, of course. So the hippocampus is like the instrument that writes down your memories. So it sits down here in the medial temporal lobe. And so when you have an experience and you want to encode an episodic memory, or you learn a new fact, you want to encode a semantic memory, or you learn a new skill. It's actually less involved in skill formation, but this helps you write that memory into association cortex. So the example I used was, say there's an image of a memory that you want to store in your long-term memory. Visual memories are going to be stored in visual association cortex. So if primary vision's out here, association cortex might be, say, out here. And so the hippocampus helps you write down your memory in your association cortex here. Or if instead of vision, you wanted to write in your sensory association cortex, because the memory you have is the memory of how bad it hurt when you got stung by a wasp, then that's going to get written down here. And the role that the hippocampus plays is in helping write down or encode those new memories in association cortex. The memories aren't actually stored in the hippocampus, but it's instrumental in encoding and storing those long-term memories.
Okay, thank you.
Thank you for asking.
All right. If there's no more questions, thank you guys all for coming to our first lecture this year. It was really great. Thank you, Dr. Sutherland, for a great lecture. If anyone has any questions, feel free to stick around and ask me or Dr. Sutherland or anyone. But if not, you guys are free to go. Have a great night, everyone.
Thank you.
Yep, thank
Thanks
you.
for having me.
Yeah, of course.
Thank you.
Have a good evening.
Thank you.
Thanks, Harry. That was awesome.
Thank you. This was fun. If you have any other slots, happy to help out.
I'll let you know. It was good.
I'll hang out a little bit longer in case other people have questions.
Do either of you guys have any questions?